Dwarika team, you can start streaming. We will be starting in another 1 minute.
Yes, sir.
Okay, we can start recording. Good evening, everyone, and welcome to the 21st Masterclass of Jaipur Surgical Tutorial. Jaipur Surgical Tutorial is an online education portal that we started in April 2021, so it's about 4 years now at the Mahatma Gandhi Medical College and Hospital, and my faculty colleague, Dr. Anand Nagar, who is a professor of HPB surgery and liver transplant with me here in MGMCH. He's been looking after the Jaipur Surgical Tutorial. For new students who have joined today or who would be watching the video, this is the free educational portal where every Saturday morning 9 to 10 a.m. India time, we conduct an academic session where usually students present cases which are discussed by the faculty. Sometimes students present an operative procedure also, indications, contraindications, preparation, technique, and complications. And again, these sessions are moderated by faculty. And from time to time, we have faculty lectures, especially on associated sister specialties, which are useful to you when you are appearing in your theory exam. So all these sessions are on Saturday morning, 9 to 10 a.m. In between, I will project a slide which will tell you how to join Jaipur Surgical Tutorial by contacting Dr. Anand Nagar. All the videos of previous more than 200 sessions have been recorded and uploaded on the YouTube channel by Gastro University, courtesy my former fellow and colleague from SCPGI, Dr. Avinash Tak, Dwarika Hospital in Ahmedabad, and his team. So you can watch these videos on that channel. And last year, about 1.5 years ago, we thought that we will extend the Jaipur Surgical Tutorial to start a monthly masterclass. This is held every Wednesday, Thursday, last Wednesday or Thursday of the month, 7 to 9 p.m. India time, where a single theme is discussed by a panel of about 6 to 8 faculty members and moderated by 2 senior colleagues. And we've conducted masterclasses on various single theme topics. Again, all the masterclasses have been video recorded, and the videos are available on the YouTube channel of Gastro University, so you are free to watch them. In between, I will project the link also. So today's masterclass is 21st in the series, and the theme today is liver resection. This actually is an on-demand masterclass because sometime in between, I received an email from some students that they would like to know more about the technique of liver resection, and that is why this is there. And I request students to please suggest topics which you would like to be discussed, which will be of use to you primarily, first to pass your exam and then to practice as a GI or HPB surgeon. So since the topic is liver resection, I thought that there would not be a more appropriate person than my colleague, Dr. Naimish Mehta, who's the professor of HPB surgery and liver transplant at our hospital now for more than 1.5 years. He was earlier the chief transplant surgeon at Sir Gangaram Hospital in New Delhi. He's also the director of Center for Digestive Sciences. My institution, the Mahatma Gandhi Medical College and Hospital, is unique in the sense that we have all 4 departments related to digestive sciences, which is medical and surgical gastroenterology, hepatology, and HPB surgery. And they all combined with organ transplant, anesthesia, radiology, interventional radiology, critical care medicine, and other related specialties constitute the Center for Digestive Sciences, which includes liver transplant also. And we have a thriving liver transplant program performing anywhere between 3 to 5 liver transplants a month, mostly living related, but a few deceased donor also. And we have the distinction of performing rare transplants like ABO incompatible, dual lobe, ALF in a child, and several other difficult procedures. more about that when we conduct another masterclass on transplant with Dr. Naimish Mehta. But for today, the theme is liver resection. So I will introduce the speakers for today. Dr. Mohammad Younis is at SKIMS in Srinagar. He has contributed to an earlier masterclass also. Dr. Saurabh Galodha is my younger faculty colleague, my former fellow from SGPGI. He is now in the faculty of GI surgery at All India Institute of Medical Sciences. Dr. Mukesh Olaniya is at Max in Delhi. And I'm very happy to announce a new entrant, new in the sense that this is the first time probably that a Jaipur surgical tutorial student is participating as a speaker in masterclass, and I welcome Mrunal Awalekar, who's at Amrita, Kochi. She's an MCH third year resident. Thank you, Mrunal, for agreeing to make this presentation. And actually, Dr. Puneet Dhar very much appreciated, and Dr. Puneet Piyush Thani further cemented his appreciation that it is good that not only young faculty colleagues, but students are also joining in as speakers in masterclass. And I hope to see more and more exam going MCH and DNB students as panelists, because then senior faculty colleagues like Dr. Naimish can play the role of moderator. So before we start, I would hand over to Dr. Naimish to make some introductory remarks, and then he can invite Mohammad to make the first presentation on nomenclature, because I think that's an important topic. Students should be clear about what is what, and they should be able to answer that when asked either in the theory paper or in the practical exam. Over to you, Dr. Naimish, please.
Thank you, Dr. Kapoor, sir, for such an eloquent introduction. So when we talk about liver resection, as rightly pointed out, this is some part where not everybody or every institute is able to hand it over to the residents who are training with them, and they may not have been exposed to a good amount of liver resection. So if you understand the nuances of liver resection, I'm pretty sure that whether you have seen it or not, you'll be able to manage it whenever you encounter such a problem in your practice. So I would like to invite Dr. Mohammad Younis, who's going to speak to us on about nomenclature, which is equally important, because when we speak to each other or different institutes speak to each other, or we record, report, or publish, we need to have the nomenclature in mind, so that what we are speaking is the same language as somebody else is speaking in terms of liver resection. So Dr. Mohammad Younis, over to you, please.
Thank you, Dr. V.K. Kapoor, sir, Dr. Naimish, sir, and my seniors and my colleagues. Today, I am Dr. Mohammad Younis from SKIMS. I am working as an assistant professor in the department. And today I'm going to talk on the nomenclature of the liver resection. Can I share my screen? I'm sharing my screen.
Yes.
So I will start my presentation.
Yeah. Please go to the slideshow mode, full screen mode. Yes, good.
Okay, sir.
There is a black bar coming on the right side.
Yes, sir, it is. Yes, sir, I will minimize it. It's a taskbar. So I will start my presentation. The liver resections, according to Henry Bismuth, the liver resections are based upon the precise knowledge of the natural lines of the division of the liver, which define the anatomical surgery of the liver. Many of the advances in the hepatic surgery have been linked to the improvements in the technology, but the thorough knowledge of the internal anatomy of the liver has a bearing on the improved outcome. This is largely due to the work of the French surgeon and anatomist Claude Quinault. He in his work early in the 1957, and he recorded his research in the book The Liver Anatomic and Surgical Studies regarding the segmental anatomy of the liver. He gave the concept of the segmental anatomy of the liver. Quinault was able to closely examine the intrahepatic anatomy and demonstrate that the hepatic functional anatomy is based on the vascular and the biliary relationship rather than external surface anatomy, thereby improving the safety and feasibility of the hepatic surgery today. Kuno was he was a physician, and he worked hard on the liver anatomy. He was working and he make models of the livers, and he published his research in a book, and he gave the modern which is followed nowadays. He published in the 1950s, that is followed still now. He laid the foundation of this modern fundamentals of the hepatic surgery. So how did the nomenclature evolve? So early there were descriptive terms, inconsistent terms, not a uniform terminology. Then came the Quino's segmental anatomy in the 90s. After that, the Brisbane terminology came, which was established by the IHPBA. And in recently, we have a new terminology proposed by Nagino et al. To address the limitation of the Brisbane. So early descriptive terms were they were inconsistent terms. Only 4 anatomical resections terms exist, like right hepatectomy, extended right hepatectomy, left lateral resection, left hepatectomy, and left lateral dissectionectomy. The Quino, in his description of anatomy of the liver, it was based on the portal venous distribution into the liver. He described the liver was divided into 2 livers. He described the hemilivers, right and left, based on the distribution of the main portal vein, the right and the left. And both livers are divided into sectors according to the portal vein further divides the secondary divisions, and they form the second order division. Goldsmith, in the same year as Quino, in his book also he described the segments of the liver. This started somewhat confusion between sectors of Quino and the segments of Goldsmith. Quino divided, according to Quino's classification, he divided the liver into functional right and left by a main portal scissuri, which runs from the IVC to the gallbladder fossa. This is called a Cantley's line. The Cantley's line, it harbors the middle hepatic vein and divides the liver into right and the left liver. What are the key features of Quiner segmentation? He said that they are independent functional units with its own portal vein, hepatic artery, and bile duct. It has a vascular outflow in the form of hepatic vein and biliary drainage. They are independent functional units of the liver. And these, the liver, he said that the liver is divided into the segments by 3 vertical planes. The plane of the right hepatic vein, in which the right hepatic vein lies, the plane of the middle hepatic vein, and the plane of the left hepatic vein, in which the left hepatic vein runs. Of course, the portal vein bifurcation divides the liver into the upper and the lower segments. So the liver is divided into 3 vertical planes, like the right hepatic vein, which divides the liver into posterior segments or sectors, and the middle hepatic vein lies the main scissuri, which divides the liver into the right and left hemiliver. And further, the umbilical plane runs from the falciform ligament into the inferior vena cava, and it divides the left liver into the medial part, which is the segment 4, and the lateral part from the segment 2 and 3. The 3 main hepatic veins divide the liver into 4 areas, thus the right liver into the right lateral sector, and the right paramedian sector, and the left liver into the left lateral and the left median sector. They are usually supplied by one Glisonian sheath. So what is the Quino classification? He classified the liver into the 8 segments, segment 1 to 8, and 1 is the caudate lobe. It is located posteriorly, not in the picture. So second, third, 4, 5, 6, they are numbered in a clockwise manner. Quino is the division of the portal vein as a base of his segmental anatomy, because portal vein branching is more consistent than the biliary tree and hepatic artery. And it is based on the second order branching of the right and left portal veins. Each sector in turn consists of 2 segments. As you can see in the picture, the portal vein divides the liver into upper and the lower segments. When there's a bifurcation of portal vein, the segments are divided in the upper and the lower. The left and the right portal veins branch superiorly and inferiorly to project in the center of each segment, thus divide the liver in the superior and inferior segments. Likewise, when we take a transverse image through the superior liver segments, on the left side there are segment 2, segment 4A. On the right side superior there is segment 8 and segment 7. Likewise, this is the section at the level of the porta or the portal vein. It consists of the segment 3 below, segment 4B below, segment 5 below the plane of the division of the portal vein, and segment 6 below. So this is an image showing the segment 3, 4B, 5, and 6 inferior to the division of the portal vein. Now, how do you interpret it radiologically? As you say, the red line, which is the main portal caesura, it runs in the middle along the course of the middle hepatic vein. It divides the liver in the right and the left liver. And the further the right liver is divided with the green line, as you can see in the picture, the green line denotes the course of the right hepatic vein from the surface to the IVC. There is a liver in the anterior and the posterior sectors. Likewise, the left liver is divided into the left lateral and the medial sector. Is radiologically how you denote the segments and sectors of the liver. Then after this, there came the Brisbane terminology of the liver anatomy. To deal with the confusion in the nomenclature of the hepatic anatomy and resection, scientific committee of the IHPBA meet in the December 1998 to create a terminology committee. A terminology was sought which is anatomically correct, in which the anatomical and surgical terms agreed, and which was consistent, self-explanatory, linguistically correct, translatable, and precise and concise. After 18 months, it was accepted by the IHPBA at the World Congress in Brisbane. So this is called the Brisbane 2000 terminology of liver anatomy and resection, consisting of a new terminology. The Brisbane terminology of liver resections was unanimously accepted by the scientific committee. The task force was to deal with the terminology of the hepatic anatomy and resections and not with the anatomy per se. So what did they do? They present a set of 3 main tables and divide the liver into the successive orders. Like they replace the term sections with sectors. Likewise, the right anterior sector consists of segment 5 and 8. The right posterior sector consists of segment 6 and 7. Left medial sector consists of segment 3 and 4, and left lateral sector in this classification, they termed the left lateral sector. And they introduced the hierarchical order of the resection. So this is the picture showing the right liver and the left liver. What is the first order? So first order is the both the hemilivers, right and left hemiliver. It follows the pattern of the branching of the main portal vein, the right and the left to divide the liver, the right and left livers. Then comes the second order. The right portal vein accordingly divides the anterior sectoral branch and the posterior sectoral branch. They form the second order branches. And the third order branch is the single segment or sub-segment. And then the non-anatomical terms like wedge resections. So based on the first order division, anatomical term right, they divide the liver, the right liver, that's called right hemiliver. Accordingly, the quinoid segments are 5, 6, 7, and 8. And the term was they call it right hepatectomy or right hemihepatectomy. Likewise, for the left liver, the segment 2, 3, and 4, they divide the term was used for left hepatectomy or left hemihepatectomy, as in this picture. The right anterior sector was segment 5 and 8, and ectectomy is added to that. That forms a right anterior sectionectomy. The resection of the segment 5 and 8 is the anterior sector of the liver. Likewise, the posterior sector consists of the segment 6 and 7, and the resection of the same sector consists of the right posterior sectionectomy. The left medial sector on the left side consists of segment 4, and the terminology is left medial sectionectomy. And the segment 2 and 3, the resection is called a left lateral sectionectomy or bisegmenectomy. The right hemiliver plus left median section, as can be seen in the picture, is a right trisectionectomy. Left hemiliver plus right anterior section is the left trisecectomy. So another what are the synonyms between? There's a modified system and the old Brisbane system. The right anterior sector, it is common between the both. The section is called anterior sectionectomy, and the posterior sector is called the right posterior section. And there's a difference in the new and the old system. In the Brisbane, they call it the lateral segment is the segment 2, and the middle segment is segment 3 and 4. And alternative is a classification they call segment 4 as left medial sectionectomy, and segment 2 and 3 as left lateral sectionectomy. And they are not synonymous. Left lateral is a 2 and 3, and left lateral is only 2 in the Brisbane classification. And they call it left lateral sectorectomy. And the third order division resection from anatomical segments from 1 to 9, any of the segment resection is termed as segmentotomy. Like in the diagram, resection of the segment 6 is called as segmentotomy 6. For the two contiguous segments, we use the term bisegmentectomy. So I'm going to present a video on this sectional anatomy of the liver.
So I think Dr. Younis has already finished the talk.
No, I think he's trying to show a video, but we are not able
This
to
is
see.
not, we are not able to get anything
Yes.
on the screen.
So maybe in the meantime, you can. But before you come in, I also have 2 or 3 questions, which are more questions, and then
I will
maybe
now go to the go to the new world terminology. This is a new world terminology. I will take few minutes more.
Okay.
So to resolve the issue
Yeah, you can
of
skip
the
the video
Brisbane
and
Brisbane terminology, they propose a new comprehensive notation for hepatectomy based on the concept
you
of
can go to
Couinos
slides, Dr.
hepatosegmental
Younis.
anatomy.
Yeah, you can go
Yes,
to.
sir. I am on the slides.
Okay.
So what is the new word terminology? The general rules of the new notation are as follows. Anatomical resections, the type of hepatectomy, is expressed with the Couinos hepatic segments resected following the letter H, which stands for hepatectomy. For non-anatomical resection, the segment number is used with an apostrophe. The en bloc resection of multiple segments, the numbers of the hepatic segments resected are described in the ascending order. The number of the segments resected non are recorded at the end. Separate resection of the multiple segments are separated with a slash. Like is an example, the H hepatectomy followed by, if we had done the segment H is denoted after H, we write the segment which is resected. Like in right hepatectomy, after H we write 5, 6, 7, 8. If there are two separate segments, we write H then 2/6 when they are separate. For non-anatomical resection, we use apostrophe of the segment for partial resection of any segment. And for the additional resection of bile duct and portal vein, we use B and PV, etc. This is the example of that. For if we do a non-anatomical resection of segment 6, it is denoted by H6. For non-anatomical resection of segment 6, it is denoted by H6 apostrophe. For example, if we do a medial sectionectomy, the partial action of segment 5 is denoted by H4 and 5 apostrophe S. For right hepatectomy, we use H5, 6, 7, and 8. Likewise, if we are combining with the portal vein and hepatic artery resection, we use H1, 2, 3, 4, 5, 6, 7, 8 with bile duct resection in case of left trisectionectomy. Likewise, is an example. So this is the resection of segment 5 and 6 contiguous. This is the non-anatomical resection of segment 5 and 6. And this is the section of segment 6 and non-anatomical section of segment 5 and 7. So likewise, there are mixed combinations for different types of liver resection. So this is a right side major hepatic we use H5, 6, 7, 8 and non-anatomical 2 and 4. Like when is bile duct, we use bile B and MHV for hepatic vein resection. In conclusion, clear understanding of the liver resection nomenclature is crucial for effective communication among surgical teams, accurate documentation, and ensuring patient safety. The standardized terminology such as Quino segmentation and description of anatomical versus non-anatomical resections, it provides a universal language that bridges clinical practice, surgical planning, and academic discussions. As liver surgery continues to evolve, the adherence to these established nomenclatures, it remains essential in guiding precise, efficient, and safer resections. Thank you.
Thank you, Mohammad. So, Dr. Naimish, before you come in, just one point.
Yes.
Maybe the new terminology, new world terminology will take care of them, but I don't know how much it has been adopted and how much it will be adopted. For example, we say that there are segments, then there are sectors or sections, and there are lobes. But then in the conventional terminology, we used to call left lateral as a segment, but it is not a segment, it is two segments. Then we said that the segment 4 is a left medial sector, but it is not a sector, it is only a single segment. And when we call caudate lobe, it is not a lobe, it is a segment. So I hope that the new world terminology will take care of this. Over to you.
So thank you, Dr. Younis, for such a fantastic overview of the nomenclature. But as Dr. Kapoor was pointing out, the new nomenclature probably will take some more time to be universally accepted. Till such time, the Brisbane classification given by the IHPB, the International Hepatopancreatobiliary Association Group, is what is now routinely accepted and has been in use for last almost 2 decades. So, though the newer convention has tried to answer some of the queries raised by Dr. Kapoor, only time will tell whether the newer convention is going to pick up or not. Because if you see, there are multiple the gradings have been given, multiple names have been given for each different sectors, and if you keep on combining various different sections or the segments, then it's going to lead to further nomenclature, adding of a nomenclature, and further complications. So till now, most of the HPB surgeons still prefer using Brisbane classification. The nomenclature here is pretty much important, is that before you go for any surgical resection, you need to know what you are going to resect. And when you record this, and if your patient has to go somewhere else for further treatment, at least the thing which you have recorded, if it is universally accepted, the center in which they are going to follow up or presenting will have a fair bit of idea what you have resected. So I think now we'll go to any questions if there are any.
Questions will come in the chat, which I will read out if they come to me. I think we can move ahead with the second presentation.
Great. So I think we have Dr. Saurabh Galodha, who's going to speak to us further and going to enlighten us about liver resections further. The anatomy, the aberrant anatomy, and why is it so important to understand what is normal, what is abnormal, and what is aberrant. Over to you, Dr. Saurabh, please.
Good evening, Professor V.K. Kapoor. Good evening, Professor Naimish, sir, and my colleagues. So I'll share my screen. Can you see, sir?
Yes. Yes.
So my topic is aberrant anatomy in liver resection. So actually, because the topic was aberrant, I have not focused too much on the normal anatomy per se, because majority has been actually covered in the previous lecture also. So I'll do this slide share. So these are few of the stalwarts who have actually done a lot of seminal work in the field of liver surgery, including Mr. Coino and Rex, Cantley, Professor Strazel and all. And this is the seminal work of Professor of Anatomy C. Quino. Actually, you can see him with his all the liver sections that he had, made in the publication eventually in 1957, which actually he described the segmental anatomy of the liver based on the portal vein segments as told by Professor Younis, and then he divided into 8 segments. And this is the original image from that publication. As far as surface anatomy is concerned, we know that the falciform ligament actually divides crudely into 4 segments, like right and left lobe. And if we go into the inferior surface, we can have a quadrate lobe and a caudate lobe. And this is the general surface anatomy of the liver. And this is the segmental anatomy, where we actually have 8 segments, in which the segment 1 or the caudate lobe is actually supplied with the separate vascular structures, whether it is the drainage from the hepatic veins or the biliary and arterial as well as portal supply. While the left sided structures are supplied, which is the segment 2, 3, and 4 are supplied by the left portal vein, left hepatic artery, or the middle hepatic artery sometimes, and drained via the left hepatic vein predominantly. And sometimes segment 4 can be drained by the middle hepatic vein. The right side is actually supplied by the right hepatic artery and its branches, which can be dividing into right anterior and the posterior sectors, and similar branching pattern on the arteries and the portal vein. And then there are the bile duct, which is also divided into the right posterior sectoral duct and the right interior sectoral duct. And the drainage is predominantly by the right hepatic vein, and sometimes some segment like from segment 8 and segment 5 middle hepatic vein can also have drainage from segment 5 and 8. So this is the segmental liver anatomy. Coming on to the arterial anatomy, there are 4 structures: artery, vein, portal vein, hepatic vein drainage, and bile duct. So I've divided my talk into 4 different segments. So as far as arterial anatomy is concerned, the most commonly quoted and the earliest work is by Mitchell, which has been published in 1966, which divides into 10 different types, in which the type 1, which is the commonest, is actually the commonest, the normal anatomy, in which the common hepatic artery gives gastroduodenal artery and becomes a proper hepatic artery, which then divides into a right and a left hepatic artery and sometimes gives the middle hepatic artery. Type 2 is where there is a replaced left hepatic artery, which is arising from the left gastric. Type 3 is where actually there is a replaced right hepatic artery coming out from the SMA. Type 4, where there is a both right and left are actually replaced. Type 5, where there is an accessory left hepatic artery coming from the left gastric artery. Type 6 is where the accessory right hepatic artery is there. Type 7, both right and left are accessory. That is, the main arteries are there, and we also have accessory arteries. Then type 8 is where actually the replace right with an accessory left is there. And then comes the type 9, where actually the common hepatic artery per se is coming from the superior mesenteric artery. And a very rare variant is where common hepatic artery is said to be coming from the left gastric artery. So this is the Michel's classification. But over the years, many classifications have been proposed, and few of them actually have been in use. One of them was actually the Hyatt's classification, which actually tried to simplify the large number of variants that were described by Mitchell. So in Hyatt actually described it into 6 types only, in which actually the type 1 is the normal variant, while the type 2 is where there is a replaced right or a replaced left hepatic artery, replaced or an accessory right hepatic artery. On the other hand, type 3 is where actually there was a replaced right hepatic artery either coming, or there is a replaced left hepatic artery, as you can see. And then there is a type 4 classification, in which there is a right hepatic artery and a combination of a left hepatic artery. And then comes on to the type 5, where is the CHA is coming from the SMA, and finally CHA coming from the left gastric artery. So this was Hyatt's classification. When I went through the literature, there are a number of studies which describe the arterial aberrant arteries, and you can see actually even some of the publications from India also in 1996. And then there are other classifications which tell that the most important thing is that the variation is to the tune of 25 to 45 to 50% actually can have a variation in the presence of a right or a left or an accessory or a replaced arteries. very recently, actually, about 2020, a new classification has been given by the 3D vascular presentation, in which a CRL classification was proposed by Yan et al. And they said that the C was actually the common hepatic artery, the R was the right hepatic artery origin, the L was the left hepatic artery origin, and the annotations below were actually depending upon from where the common hepatic was coming, where the right hepatic was coming, whether it was a replaced or an accessory, and similarly for the left, and the combined CRL classification was proposed. So there are actually only 9 subtypes to CRL classification, but if you go further divergence, then total 25 subtypes were described by Yan et al. In this British Journal of Surgery. And in this case, the type 1 was the normal anatomy. Type 2 was where there was a replaced right. Type 3 where there was an accessory right. Type 4 where there was a replaced left. And type 5 where there was an accessory left. Type 6 is where both right and left are replaced. Type 7 can be a combination of a replaced right with an accessory left or a accessory right with a replaced left. Type 8 where both accessory right and left are present. And type 9 where actually the common hepatic artery itself is arising from a different source, whether it is aorta or a left gastric or an SMA. So this is the newer classification. Why they actually compared these classifications with Hyatt as well as Mitchell. And if you can see that when they compared, they found that the CRL was able to describe almost all the subtypes of in all these studies. On the other hand, the Mitchell's concordance was to the tune of 80 to 90%, but in many of the studies, the concordance was only up to 80%. And what are the clinical implications? So if you can see this type 2G, where actually there is a replace right from the GDA, if there is a surgery being done and this GDA is ligated, then there can be a hepatic ischemia. And we all know that whenever we are ligating the GDA, we actually palpate in the hilum and after applying a Babcock, so that we know that the supply of the liver is not coming from the GDA itself. Then another one is where actually hepatic artery reconstruction, actually in one of the studies it was shown that when there was a donor common hepatic artery and a recipient right hepatic artery were anastomosed, and there was a donor aberrant left hepatic artery and recipient left hepatic, there was sort of a GDS-TL syndrome, and which could lead to a ischemic damage of the graft liver. And finally, there was another one where the type 6G, where actually there is a replace right from the GD and the replace left from the left. This case, liver transplantation, it was found out that there could be a gastric or a duodenal hyperperfusion. So that's why describing and actually knowing the anatomy, arterial anatomy, is very, very important in terms of liver dissections and liver transplantation. Then segment 4 arterial anatomy per se has been separately described. And in this case, there are 4 types in which could be there. The most common is where it is coming from the right hepatic artery. Then second most common is from the left hepatic artery, which could have different variants, whether it is coming straight from the left hepatic or coming from segment 2 or 3, or there's a trifurcation of 2, 3, and 4. Then straight away coming from the portal hepatic, proper hepatic artery, and there can be 2 supplies. There could be 2 arteries which could be supplying the segment 4. So then coming on to the portal venous anatomy, we all know that the portal vein actually develops by the involution of right and left umbilical vein and joining, and right and left vitelline veins. And eventually, we have a normal anatomy where the splenic vein joins with the superior mesenteric veins and forms a portal vein, which then enters the liver and divides into a right and left portal vein, and right then further divides into a right anterior and a right posterior portal vein. What about the aberrant anatomy? So commonest variant which has been described in various literature is that the right posterior is actually dividing first from the main portal vein, and the right anterior is then coming from the left portal vein. And this could be vice versa also, where actually the left portal vein could be arising from the right anterior portal vein. Then there is a trifurcation where all 3 are actually coming at the same source. And finally, there could be a very usually encountered very rarely, where there are multiple branches and no single right or left portal vein is there. There are again similarly, as I said, there are multiple classifications described in the literature. The arteries classification, which actually also described the complete absence of a right portal vein or a left portal vein, and then the supply was actually from the other side. Then there very recently in Nakamura classification from the liver transplantation, which is important because if there is a trifurcation or if there is a right anterior portal vein which is arising from the left portal vein, then when we are taking a graft, we could actually have two holes and two different portal veins which have to be anastomosed, and technicalities, technical variations have to be taken care of. Then again, a newer classification which has been published just now in last year only is the branch level based classification. Not going into the details, but mostly it is the type 1 is the classical, type 2 where actually right portal vein is absent and the supply is from segmental veins, type 3 where it has been described the left portal vein is actually absent and everything is being supplied from the right side, and type 4 where actually one of the segmental veins is absent, that is either right anterior is absent or right posterior is absent. But this is too complex and usually not yet very much in vogue. So maybe it will take some time before all the technicalities which are associated with this are made use. Then this is not actually an anatomical variation, but this slide actually shows that if the origin of a tumor is per se an intrahepatic or an extrahepatic, on the imaging, the orientation of the left portal vein can actually guide you whether it is an extrahepatic or an intrahepatic compression. As you can see, the orientation has changed from north to south to actually east-west, or a more horizontal rotation for the left portal vein. Then coming on to the bile duct anatomy, we all know that the variation is actually the norm in bile duct anatomy. This is the initial publication by Kuno itself in 1957, which showed that the commonest is actually the one we always describe, that the common hepatic duct dividing into right and left hepatic duct, and then further dividing into right anterior and right posterior. Then the second most common being that kind of a trifurcation itself, where right and anterior and posterior are just joining at the level where left is taking off. So there are various, all of these variants are there, where is the right posterior is actually arising from the left hepatic duct, or right anterior is arising from the left hepatic duct, or very rarely all different segments are actually being supplied by different ducts. As you can see that all segments have their own supply. So this is very, very important, because if there are if you are taking a graft or if you are doing a resection and there will be multiple holes, and then if you don't know preoperatively, then you won't have planned for the surgery, and the difficult anastomosis that you actually encounter at the time of resection or graft retrieval makes life very, very difficult. Then these again similarly many classifications, Huang's classification, Hokubo's classification, 2008, then Chemptier's classification as far back as 1994, which actually describe more or less the same pattern of division of right and left hepatic ducts and right anterior and right posterior ducts. Then another is this classification actually more holds true for the cholecystectomy or a safe cholecystectomy or avoiding a bile duct injury, where actually the right posterior duct would be joining with the cystic duct. Either the cystic duct is joining the right posterior, or the right posterior is joining the cystic duct, or there is a low insertion of the right posterior duct. So this is in terms of when you are actually doing a cholecystectomy that you might injure the posterior pedicle. Then the Hodgson's hook, which we all know has been described as far back as 1951, where actually the right posterior duct hooks behind the right anterior portal vein, and this can have two orientation. One is the north-south orientation. So the south orientation is actually where it is going below the right anterior sectoral portal vein. So even if we divide an early division, we may not really injure. But if there is a north orientation, that is, it is going behind the main and then going behind the right anterior portal vein, then if you divide closer to the origin, that can lead to actually injury of the right posterior sectoral duct, especially when you're doing a right anterior sectionectomy, or if you're trying to preserve the right posterior duct. So then separately divide variant left hepatic duct anatomy. The most commonly is actually the segment 4 arising from the left hepatic duct, and then further segment dividing into 2 and 3. But sometimes the 4 can come from segment 3, or 4 can 4, 2, 3, and 4 are actually causing a trifurcation. Again, mostly more commonly important when we are doing a left lateral segmentectomy, because in that case, again, you can injure the segment 4 duct, and so that can lead to bile leaks. So that is very, very important to understand from the MRCP before the surgery itself. Then coming on to the hepatic venous anatomy, we know the normal hepatic venous anatomy is the right IVC has three drainage veins, right hepatic, middle hepatic, and the left hepatic. Usually, middle hepatic and left hepatic can have a small common course and then drain into the IVC. So there are multiple variations in the right hepatic vein can be there, where actually there can be a superior hepatic right hepatic vein which is joining closer to the IVC, so which can actually be injured when you are isolating the right hepatic vein. Or there can be two different hepatic tributaries into the right hepatic veins. So these are the various classification which was described by Nakamura, in which actually there were two different right anterior superior and a superior hepatic vein, which was joining the right hepatic vein closer to the where it is draining into the IVC, that is the hepatocaval junction. Then this is the variant right hepatic anatomy. As you can see, it could be a single vein. It can have two veins with a common trunk, or it can have two different veins. As we know, there are accessory right hepatic veins also. There could even be a three hepatic veins with different trunks or a common trunk. Then, as very much described, an accessory inferior right hepatic vein, which could be supplying the segment 6. And similarly, a vein which could be supplying the segment 7. So this is the variant right hepatic vein anatomy. Coming on to variant middle hepatic vein and left hepatic vein, we know usually we have a common trunk. Sometimes, many times, both can be draining separately, and which helps especially when we are doing a left hepatectomy, because we can isolate the left hepatic vein. The important one is when the segment 4 is actually draining into the middle hepatic vein, because if we are doing a left hepatectomy, a right hepatectomy, and we take the middle hepatic vein, then the segment 4 can actually be can get congested, and that can lead to poor FLR, which can eventually lead to a liver failure. So this is an important variant, and we should know about this one. Then there can be accessory veins, and then one more important vein is where there is a dominant middle hepatic vein, which is actually supplying segment 6 also, draining segment 6 also. So if we are taking this middle hepatic vein and during a left hepatectomy, if this is taken, then the segment 6 can get congested. So if we have a knowledge that this is being drained by the middle hepatic vein, then probably we'll take middle hepatic. We'll try to avoid taking middle hepatic when we are doing a left hepatectomy in this case. Then coming on to the inferior right hepatic vein, as I previously mentioned, it can be three types. One is where there is no inferior hepatic vein, one where there is very small, which can actually be easily ligated, and there is no issue with that. Or if there is a fairly large vein actually supplying one of the segments, it can sometimes help you, because if it is supplying a segment 6 and you want to preserve that segment, then because the drainage is already there from the inferior hepatic vein, you can take care of, suppose there is a tumor which is involving the base of the right hepatic vein, and you want to save segment 6, which is currently being proposed, especially in the parenchyma preserving surgeries that are being proposed as of now, because we all know as much as parenchyma is preserved, it is always better. So you can do a resection closer and save the segment 6, because it will be supplied by it will be drained by the inferior right hepatic vein. So coming on to the conclusions, basically, we all know that the variants are actually the norm in liver anatomy, and appropriate knowledge of vascular as well as biliary anatomy is very, very essential when we are planning the surgery, because one, we can avoid the complications. Two, we can work around and save the parenchyma as much as possible. And three, we can actually predict the complications and then take appropriate measures. And this is very, very essential when we are doing surgeries like major liver sections or liver transplantations. Thank you.
Okay, so before Dr. Naimish makes his comments, one is that all students should know that just as two cities do not have the same map, I think two livers do not have the same anatomy, especially the intrahepatic anatomy. And unlike the hepatic artery, portal vein, and bile duct, the veins are shared by segments. So there is no vein which will be draining only one segment. They will always be shared. And very important point which Saurabh made is the displacement. It is not an aberration, but a large space occupying or extrahepatic parahepatic lesion which has displaced the anatomy. And I distinctly remember one case where we were doing the same procedure as you described, left lateral segmentectomy, and the left portal vein was so displaced that when we took the left portal vein, we took it beyond the segment 4. And then we had to unnecessarily convert a left lateral into a left lobe. So this is very important. But I would request Dr. Naimish to make comments about the role and importance of these variations, both when you are doing a liver resection for a lesion and more importantly, when you are planning to take a graft, because that is where it is the most important. Dr. Naimish, please.
So Saurabh, I think, has addressed this issue pretty well in his presentation. And as he has rightly pointed out, anomaly is actually a norm. And since we have been doing liver transplant, most of the surgeons find that about half of their donors do not have the normal described or so-called normal described anatomy. So they are all not an abnormality, but they are anomalies. So that is what is very important to remember. And whenever you are doing liver resections, he has actually touched upon a couple of things while he was presenting. And in each point, depending on the anatomy, if you are aware of that, you'll be able to modulate your liver resection based on the knowledge of the anatomy. And it is not only liver resection, because some of these cases would affect even in your Whipple surgery, as is also pointed out, that if the supply to the right it's replaced, the right hepatic artery is replaced, or it is coming through the GDA and there's a celiac trunk stenosis, in those cases the supply will come from the SMA via the GDA, and that is where you need to keep in mind how you will change your plan of resection. So that is something pretty much important. In terms of liver transplantation, you have to decide the donor anomalies or the anatomy based on which side of the graft which you will be taking. It is right, left, or a left lateral. Sometimes we have done left lateral, which is having a multiple arterial inflow, and you end up doing in left lobe we have done 3 arteries, in left lateral we have done 2 arteries, 2 hepatic veins. So all those combinations, they do keep on coming. So if you are aware of that, one, you will avoid any major complications and bleed intraoperatively. And two, you will also be able to avoid any major complications post-operatively, which may happen if you have inadvertently ligated a major vascular pedicle to the remnant liver. So I think if there are any questions there, Dr. Kapoor sir, if none, then maybe we can.
Not yet. Actually,
Okay.
what I
So
tell all the panelists in master classes is that don't go by the number of students who are attending now. That number will be 10, 20, 30. But tomorrow morning, I will post more than 100 students would have watched this video. And in fact, some of the master classes, the views have crossed even 1,000. So your effort is not going to go waste. A lot of students are benefiting from these master classes. Sorry, Dr. Naimish, I interrupted you. You were saying
no,
something.
that's absolutely fine. I think very rightly said. So this the whole intention of these classes were that it doesn't help only a few people, but it reaches the mass where it is supposed to. And the second part is it has the you can recall it. So that is one of the major thing. You can watch it again if you have not had time to listen to the whole session at this period. You can probably come back, and when this will be available on the YouTube, where you can watch it at your convenience and at the time of your place or wherever you find it convenient to watch. So now we have had two of our fantastic speakers speak to us about the nomenclature and the anatomy and what to do in a liver resection. But now we have Dr. Mukesh. They say that a good surgeon knows what to operate, but a better surgeon knows when not to operate. So Dr. Mukesh is going to throw some light on when not to go in and venture and do a liver resection. Dr. Mukesh, over to you, please.
So before Mukesh starts, again, the same point I would also like to highlight that all of you, the young surgeons and students, have to know that when you should not be operating. And this is important not only from exam point of view, but from practice point of view also. And Mukesh is a new panelist for master classes. I welcome Mukesh. And in fact, I'm very happy to say that his name was suggested and recommended by Dr. Piyush. So he has a strong backing of one of the most respected GI surgeons in the country, Dr. Piyush Sani. Mukesh, over to you.
Good evening, sir. Thank you, sir, for giving me opportunity, Dr. Kapoor, sir, and Dr. Naimish Mehta, sir. I'm not, my screen is, just a moment. I don't know why it is not coming full.
We were seeing it
Yeah,
actually.
yeah, now I can see it. Yeah, yes, sir. So,
You can go on the full screen because we are still seeing your left panel.
yeah, yes, sir.
Yes.
Now you can see, sir.
Yeah, but we are still seeing the left panel also with multiple slides. Maybe you
Oh.
can.
Yeah,
Yeah,
now it's
that is
okay.
better. Yeah,
Yeah,
please go ahead.
yeah. So my topic is liver lesions which do not need resection. So detection of the asymptomatic liver lesions is increasing day by day due to the widespread use of modern radiological imaging and routine checkups by the patient himself and by doctor. And what is important is differentiating between the benign and malignant liver lesions to avoid the unnecessary surgery. And benign and low risk lesions are suitable for observation, and radiology is very important for the diagnosis, and examination of liver biopsy or resection is specimen sometimes is needed to establish the diagnosis when radiographic investigations fail to do so. So, the differential diagnosis of benign hepatic masses lesion can be challenging, especially on needle biopsy, for which sometimes IHC is also being used. So, usually, when these lesions are not advised to have resection when it is asymptomatic, benign radiological features, stable in size on follow-up imaging, and no suspicion when there is no suspicion of malignancy, and and there is no complication in the form of bleeding, rupture, and obstruction. So these are the most common lesions which do not need resection, like hepatic hemangioma, FNH, adenoma, hepatic cyst, regenerative nodule, hematoma, hepatic AML, and calcified hydatitis, hepatic abscesses. So first we'll discuss about hepatic hemangioma. Typically arise in middle-aged women, and female to male ratio is 5:1. Commonly doesn't show any symptom, and usually a single. And there are different types: cavernous, capillary, mixed, sclerosing hemangioma, and size is sometimes few millimeters to 3 centimeter most commonly, but many series has been reported even size more than 20 centimeter. And usually these lesions are arise in right lobe of the liver. Grossly they are spongy red appearance, typically beneath the capsule, and giving appearance of red violaceous capsular blotch. A proliferation of variably sized dilated vascular spaces fed by the hepatic arterial circulation. These spaces are lined by the single layer of blend endothelial cells with and separated by the fibrous septa. Larger septa may contain thin walled vessel and bile duct. Older lesions may sometimes have involutionary changes, including necrosis, thrombosis, calcification, ossification, and there has not been any reported uh, malignant transformation. Then on USC, these are usually homogeneous, hyperechoic. On CT, discontinuous enhancement pattern is present on arterial phase. On portal phase, usually a progressive centripetal enhancement. On MR, T1, typically hypointense, intense, and on T2, they show hyper intense lesion showing light bulb sign. So, larger lesions sometimes may have heterogeneous appearance with the areas of fibrosis, necrosis, and cystic changes with the coarse calcification. And sclerosing hemangioma is a variety where degeneration of cavernous hemangioma happens, and it shows similar imaging finding to sometime like a malignancy, like cholangiocarcinoma, and rim-like gradual persistent enhancement, capsular retraction. ADC value on MR of sclerosing hemangioma are usually higher than the malignant tumors. So this is the microscopic picture of showing hemangioma, showing proliferation of the dilated space lined by the endothelial cells separated by varying septa. Then this is lesion is a kind of variety of hemangioma. It's epithelioid hemangioendothelioma, not exactly hemangioma, but it's a biological behavior between angiosarcoma and hemangioma, and it usually require resection on imaging. It's a hypervascular coalescent lesion and stratified pattern with concentric ring of varying intensity, as you can see, and referred as a lollipop sign. And persistent lesional enhancement on delayed hepatobiliary phase is present, and these lesions usually require resection. Otherwise, normal hemangioma doesn't. Then second comes is the focal nodular hyperplasia. It's the most common benign lesion after the hemangioma, usually asymptomatic, non-hormone related, most commonly in women in fourth or fifth decades of life, around 0.8% in general population, and range from 1 to 20 in size. And multifocal can be there in 20% of cases. On imaging, usually central scar with spoke wheel pattern and arterial enhancement usually present, and calcification necrosis are extremely rare, and there has been no malignant potential. But these focal nodular hyperplasia needs to be separated like FNH like lesions, which sometimes happens in hepatic outflow inflow uh, disturbance, and chemotherapeutic agents and stem cell transplantation. Usually FNH are single or multiple, but FNH like lesions are usually multiple. On MR, usually FNH are intense to the parenchyma, but T1 or FNH like lesions may show T1 hyperintensity. And background of the liver in FNH usually is normal, and FNH like lesion abnormal because of chemotherapeutic agents or radiation, and histopathological hyperplastic hepatocyte nodules without normal portal tract are present in FNH. But in FNH like lesions is similar to FNH but with abnormal background liver parenchyma. So on radiological features, on CT, usually intense on arterial phase and isoattenuating to liver on portal venous phase, and delayed phase may show central scar. On T1 MR is iso or hypointense. On T2 usually slightly hyperintense, and central scar is present which is hyperintense. So this is the microscopic picture of showing FNH, which is characterized by the central scar and radiating septa, and hepatocellular nodules separated by the thick fibrous septa. So this is the ESL, European Association of so, a liver society, showing how to work up and manage these lesions. When you suspect FNH, then contrast imaging has to be done, preferably MRI. And if FNH is certain diagnosis, then there is no follow-up is needed. And if there is a doubt, then lesion less than 3 centimeter or more than 3 centimeter, when less than 3, contrast enhanced US. If diagnosis is confirmed, then just follow up. If more than 3, then sometime when you are in doubt of diagnosis, then biopsy can be done to prove the FNH. And usually these lesions don't require resection. And third comes the hepatic adenoma, that is most common in middle-aged women, and increased risk of hepatic adenoma is seen when these have history of estrogen and androgen containing steroid medication, type 1 glycogen storage diseases, diabetes mellitus, congenital or acquired abnormalities of the hepatic vasculature, then portal vein absence or occlusion, or portohepatic venous shunt. So there are different types of adenoma. First one is inflammatory, which is most common, 40 to 55%, often in women associated with obesity, diabetes, steatosis. High risk of hemorrhage. And then second was HNF1 alpha, 30 to 40%, low risk of hemorrhage, minimal risk for malignant transformation when size is less than 5 centimeter. Beta catenin, which is the highest risk of malignant transformation, then unclassified 5 to 10%, then sonic hazog, where is the highest risk of hemorrhage. And now the new variety mixed inflammatory and beta catenin, risk of hemorrhage as well as malignant transformation. So enhancement pattern usually hyper enhance on arterial phase, and vasodilation is present in HNF mainly when the variety of beta catenin and HNF1 alpha, and persistent enhancement is present in inflammatory subtypes. This is the different variety of adenoma, which is hepatic adenomatosis, usually multiple more than 10, absence of any correlation with steroid medication, and equal presence in both men and women. And then what can be the complications due to adenoma? First is bleeding, usually in 27%. Patient factor usually OC pills or obesity. Lesion factor when size is more than 3.5 centimeter. Left lateral segment exophytic, visible arteries in the lesion, and sonic has of HCA. And malignant transformation can be present in 4 to 8% when lesion in more than 5%, and subtypes of beta catenin and mixed variety. And on imaging, there is a growth on the sequential imaging, and vascular invasion is present. This is the European guidelines. When you suspect adenoma, contrast MR has to be done. If it's a female, just advise lifestyle changes. If a male, irrespective of the size, it should be resected. And in female, after even advising lifestyle changes, repeat MR after 6 months. If less than 5 centimeter, and even after 1 year, the size is reducing stable, then just annual imaging. But if size is increasing more than 5 centimeters and significant, then it can be resected. Otherwise, the resection usually is not advisable. So hematoma, next one is the liver hematoma. Is a benign developmental malformation of the liver, not a true tumor, but rather disorganized overgrowth of normal liver component. First one is the bile duct hematoma. Second is the, which is also known as a von Meyerbeer complex. It usually doesn't require any resection. And mesenchymal hematoma is a parenchymal hematoma. Sometimes usually require resection. Yeah, it's large multicystic benign masses, and most commonly occur in children when less than 2 years of age, can cause abdominal distension. On CT, bile duct hematoma, usually multiple small hypoattenuated nodules. On MR, T1 hypointense, T2 hyperintense, no treatment is required. But for mesenchymal hematoma on CT-MR, they are large cystic masses with septations, may have solid component as well, and they require resection. So regenerative nodules are usually seen in background of cirrhotic liver, often multiple and benign. These are distinct from the dysplastic or HCC nodules. And MRI on regenerative nodules in cirrhotic are iso to hypo intense to the background of liver on T1 and T2 images, as well as post-contrast images. And these are managed with the regular surveillance and needs to be differentiated from the developing HCC in the background of liver cirrhosis. Here you can see the regenerative nodules on MR. So simple hepatic cyst, again, it's a congenital fluid-filled cyst, is usually asymptomatic, anechoic on US, and usually no intervention is required in these until and unless patient is having pain, infection, or hemorrhage. Hepatic angiomyolipoma is usually a very rare tumor, more common in kidney, and most commonly situated in the right lobe, and usually treatment is not required, just observation and follow-up. Then hepatic abscesses can be due to multiple reasons. Usually these lesions do not require any surgical intervention. And there is usually a rim enhancement pattern with the hypoattenuation. And hydrated cyst, if it is calcified, WHO classification C4 and 5 usually do not require resection. And the most important thing in this is a diagnostic approach. So first, how to approach these lesions. So when you detect the liver lesion on USG, contrast imaging in the form of CT or MR has to be done. Usually hyperenhancement with no washout is present in hemangioma, FNH, adenoma, hypervascular metastasis, epithelioid hemangio, endothelioma, and NRH. And hyperenhancement with washout is present in HCC, adenoma, hypervascular metastasis, primary NET, sarcoma. And rim-like enhancement or hypoenhancement is present in hypovascular metastasis, intrahepatic cholangioCA, abscesses, granulomatous in lesions, lymphoma. No enhancement is present in simple cyst, and echinococcus, MCN hematoma, and necrosis, parenchymal changes, and isoenhancement in fatty infiltration. Then take home message: most benign liver lesions do not require surgery. Importance of accurate radio imaging is very important to distinguish between these lesions and differentiate from the malignant lesion. Multidisciplinary follow-up is essential, and it helps to prevent the over treatment and unnecessary surgery when these lesions do not require any resection. And differential diagnosis for lesions can be narrowed based on their enhancement pattern, specifically MRI when there is a doubt. And clinical inputs like history of OCP, hepatitis, primary malignancy, LFTs, tumor markers, and imaging can help in separating these things from the malignant lesions and to differentiate from each other. Thank you.
Thank you, Mukesh. So before Dr. Naimish comes in, two questions or points I would like to ask you. One is that if you see a space-occupying lesion on ultrasound,
Yes.
what do you recommend as the next investigation? Should it be CT or MRI?
Sir, usually we recommend MRI.
And any
As a
specific?
policy
Yeah.
at our institute, because it helps in differentiating, because most of our patients are having liver cirrhosis, and it helps us to separate these from regenerative nodules and HCC. And even when patient is not having cirrhosis, the better characterization of lesion is present with MR rather than CT.
And is it a standard MR, or do you need to give some special requests to the radiologist?
This is triple phase MRIs.
And my second question is the algorithm which you presented. Now, this is the most important thing, that when we see a space occupying lesion, if it is not classical of, say, HCC,
Yes, sir.
then the dilemma starts.
Yes, sir.
And what to do and what not to do. So
Yes,
any
sir.
practical tips which you can give to the students from your own experience as to what would suggest that it is more likely to be HCC, and what would suggest that you can probably wait and see what is happening?
First is any history of viral hepatitis in the form of Hep B, Hep C, which are more likely to have HCC. And the what is the background of liver? It is cirrhotic or non-cirrhotic, which also helps in isolating all these things. And the other thing is tumor marker also helps in these when there is a dilemma many times. Yes.
So, Dr. Naimish, from your vast experience, this dilemma that suppose we've done CT, MRI, both, and it's not classical HCC, but we are not sure what it is, and we don't want to take either risk. We don't want to resect and then end up with a completely benign diagnosis. On the other hand, we don't want to sit on an HCC. So any practical tips which you would like to give to the students, both for exam and more importantly for their clinical practice?
So, first of all, I would like to congratulate Dr. Mukesh for such a eloquent talk. It's a difficult topic, I think, but he has tried to address it very nicely. Coming back to your question, we need to start right from the history. You also need to see the age of the patient. You need to see the gender of the patient, because some of the things which Dr. Mukesh has rightly pointed out, some SOLs are much more common in females. Multiple lesions are more common in females. In specific diagnosis, it is seen in a middle age, not in the younger age group. So when you are comparing, so all these matter is when you are taking history, it is very, very important. Do not, I would say, use any shortcut for your history. So your history is pretty much important. Any exposure, because sometimes you are not able to see a classical hydrated cyst, or you're not able to see a classical abscess the way the rim would enhance, or even a treated or a partially treated abscess can actually falsely give you an appearance of a tumor. And that is where, in my opinion, you are very much worried of not operating, because most of the other lesions, if the background liver is cirrhotic, you would definitely think more in favor of its malignant lesion. There is a LIRAD classification giving on the CT scan, which is definitely helpful. By the radiologist, he'll be able to classify and categorize the type of the lesion into the lyrides group, and if it is lyride 4 or 5, then again more in favor of malignancy and you should probably resect. If the background liver is non-cirrhotic, then you also need to know what Dr. Mukesh was trying to point out is whether the patient had viral hepatitis. So in a non-cirrhotic viral hepatitis B liver, you still tend to get a large HCC, which are usually fibrolamellar HCCs, and again these would need to be resected. When you actually, now the other point which we were discussing is the history will try to point out if any treatment has been given in the past, whether the patient has got fever, because that would again point towards an infective focus. The worst case scenario, if you still feel that all these things you have actually evaluated and the lesion does not fit into any one of them, and you think that it is still more in favor of an inflammatory lesion, then maybe doing a biopsy would be worthwhile before you actually go ahead and start operating on these patients. One of the dictums as a surgeon, what we all learned is if you are able to resect in a liver SOL, then most of the time we do not use to do a biopsy. But with the latest advantages with our IR guys, the interventional radiologist guys, they can actually embolize the tract. They also use the Seldinger technique where they are using the cannula through which they are going to put the trocar or the needle, and hence the chances of seedling has reduced significantly as what we used to see while during our residency time. So these are the few points I think which will be very much useful to the resident in terms of differentiating between an inflammatory mass, a benign lesion, or a malignant lesion. And then worst case scenario, probably you should, if you're still in two minds and you're not sure, you would want to offer a resection, then biopsy should not be forgotten. It is still much more helpful in today's scenario.
So would I be right if I say, to just to paraphrase what you said, that if we are planning to resect, then biopsy is not required. If we are not planning to resect, then you want to be sure that it is not malignancy. Would that be the correct?
Absolutely right. Absolutely right.
Now, second point I wanted to ask you was about the biopsy again, that how low or high should be the threshold to biopsy? I mean, from your experience, would you be able to tell a rough range that out of 100, say, liver resections for a space-occupying lesion, how many times would you have done a biopsy?
Dr. Mukesh, you are asking Dr. Mukesh? I think he.
Yeah, Mukesh
Yes,
can
sir.
Mukesh can take that.
Yes, sir. For if it is characteristic lesion on imaging and which require resection, our policies do not do biopsy. But sometimes we get patient when biopsy is done outside. For us, I think hardly any, maybe less than 5% if we
So
have it.
very low
Very rare,
biopsy.
very rare.
Dr.
Yes.
Naimish, would you like to?
I think 1 in 100 is what we would probably be going towards a biopsy where there is a serious diagnostic dilemma. Otherwise, with the latest advent of the radiological techniques, we are usually able to identify, and if they are, as Dr. Mukesh has rightly pointed out, if it is resectable without causing any major comorbidities. In the current scenario, the mortality and morbidity post liver resection is less than 1%. And hence, if you have even the slightest of doubt that the lesion should be resected or it is malignant, then do err on the side of resecting it.
Saurabh and Mohammad, would you like to make any comment? We still have a few minutes.
As Sir pointed out about the worst case scenario, especially those which actually look like an abscess but probably are more likely to be a tumor degeneration actually. The worst problem is that even biopsy may not give you the right information even after the biopsy. What you will be actually aspirating will either be pus or some necrotic material. So in that case, actually you have to take a complete clinical scenario starting from the history to the end point. Maybe an MR is actually a pretty good investigation with diffusion weighted and contrast enhanced, which can give you some clue to it. But yeah, even in our scenario, I don't remember over the last 50, 60 resections that we have done any biopsy except for those who have actually, and two patients actually I can recall which came as resolving abscess. but were eventually tumor degeneration and hepatocellular carcinoma in both the cases. So biopsy per se, number of biopsies is pretty low. Only because of the two things. One, that when we are resecting, we may not actually go ahead with biopsy. And two, in many of the scenarios where actually we want biopsy to tell us something, it actually does not. So we end up doing the surgery itself. So that is something which is there. But still, if it gives, even if one biopsy is giving you some clue which prevents the surgery or prevents some complication, that is good enough. That is what our protocol usually is.
And sir, one more important
Yes.
point. And Lirards is used very commonly nowadays, but it helps in only cirrhotic background. Lirards is not for the normal liver. Yeah.
Okay.
Which is very important for
So
this.
if there are any general surgery students watching this or who will be watching, you should know that renal cell carcinoma is known to present with fever, but that is as a paraneoplastic syndrome. And in fact, one of the differential diagnoses of pyrexia of unknown origin, you should mention renal cell carcinoma. But at the same time, large tumors, especially HCC and even gallbladder cancer, which is infiltrating mainly into the liver parenchyma, the tumor necrosis, the point which Dr. Naimish and Saurabh again highlighted, the patient can actually present clinically also like an abscess. The patient may actually have fever and leukocytosis. So you have to be very, very careful before you say that it is only an abscess and it is not a tumor necrosis, which is presenting and looking like an abscess on imaging. So the last speaker for today, and again, I welcome and I'm very happy and I'm very proud to say that Mrunal is the first student volunteer to be a speaker in the JST masterclasses. Thank you, Mrunal, and I really appreciate your volunteering in response to my request on JST, and very brave and courageous of you. So as a bonus, all students after any class get one chapter. You can always ask for 2 chapters from me. So please go ahead. And again, very important point that yes, there is the lesion is an indication for surgery. So it is not one of the lesions which were mentioned by Mukesh. But what are the situations, patient-related, tumor-related, liver-related, where you have to be very, very careful, or you have to think twice before you proceed, or you may not even proceed for resection? Mrunal, over to you.
Yes, sir.
And we have extra 5 minutes because it is only 20. So you take your time, go slow, and present.
Yes, sir. Thank you for your kind invitation and the kind, hearty encouragement. Thank you for this opportunity as well. Good evening to one and all. I'm going to be speaking on contraindications for liver resection. I am a third year GI surgery resident at Amrita Hospital, Kochi. I would also like to thank my professors, Dr. Sudhindran and Dr. Sudhir sir, and Dr. Shweta, who have helped me in this presentation. So coming to liver resections, perioperative mortality, even in experienced centers, is routinely 5% or less. The 3 most critical factors related to perioperative morbidity are blood loss, amount of normal liver resected, and the condition of the liver itself, like cirrhosis. The commonest indication for resection would be HCC, and the best option for management of HCC would be resection. So what are the issues with liver resection? Most commonly is bleeding during transaction. Liver is a highly vascular organ, and also in presence of portal hypertension, there are multiple intrahepatic shunts which may lead to torrential bleeding. But due to major technological advances, especially in anesthesia as well as surgery, where we have CUSA, ligashore, harmonic, and improved techniques, the bleeding can be well addressed. Another issue is the post-op liver failure, which presents as hyperbilirubinemia, coagulopathy, ascites, and encephalopathy. All of these factors predispose to sepsis, which in turn worsen this post-op liver failure, causing a toxic cycle. So reasons for post-operative liver failure is either the function of liver is inadequate due to unhealthy hepatocytes, for which we have to do a functional assessment in prior, or the volume is inadequate, that is healthy hepatocytes but too few are present, which needs a volumetric assessment. Poor liver function is seen in cirrhosis, steatosis, jaundice, and post chemotherapy. These hepatocytes are much slower to regenerate, which leads to a higher postoperative complications. Functional assessment of liver before resection. Predominances of ICG clearance as a hepatic function test. Normal ICG at 15 minutes should be more than 90% excreted. If the clearance is less than 60%, it poses a high postoperative risk. After portal vein embolization, the kinetic growth rate of the remnant liver tissue should be calculated, which is the kinetic growth rate or KGR hereafter, which may predict a safe resection of liver. Functional testing should supplement an FLR evaluation. Liver function tests help in assessing this risk as well. Child B and C are contraindications of resection. MELD score, which uses bilirubin, INR, and creatinine. So MELD over 16 is a relative contraindication. If there's presence of clinically detectable portal hypertension, such as varices, ascites, splenomegaly, or platelet counts below 1 lakh, this is a contraindication for resection. Makuchi et al. Presented this paper in 1993, in which they have proposed Makuchi's triad or Makuchi's criteria, in which they have taken up ascites, total bilirubin value, and ICG clearance at 15 minutes. So they have proposed that patients with uncontrolled ascites or bilirubin of more than 2 are not indicated for hepatectomy. So why do we use ICG? It is unique in the sense that it is metabolized microsomally in the liver and exclusively excreted via the liver into the bile ducts. Also, it is not absorbed by the intestinal enterocytes, so there is no enterohepatic circulation. It gives a really good assessment of the liver function. Coming to volumetric assessment, analysis of volumetry is done. Suppose this is the tumor and this is our proposed plane of transaction. This is the area removed and this will be the area remaining or the future liver remnant. So area remaining divided by total liver volume into 100 will give the future liver remnant or FLR. Modern CT scanners, MD CT scanners are excellent in calculating this volumetry. It also gives a 3D volumetric reconstruction of the tumor in relation to the liver, which really helps in preoperative planning and strategizing of this resections. FLR in a normal liver of at least 30% is mandatory. However, in a dysfunctional liver, this value goes up to 40 to 50%, such as patients with cirrhosis, cholestasis, steatosis, or post-chemotherapy. Patient selection is of most importance in resection. Severe liver disease, resection is contraindicated. For patient with less severe disease, 3 factors will decide if resection would be an absolute or a relative contraindication. These factors are FLR, presence of medical comorbidities, or perioperative liver failure. Whether in case that happens, their availability and proximity of liver transplantation is important. Careful evaluation is required in mild to moderate liver dysfunction. MELD score does not directly guide resection, but is useful in patient counseling and also in weighing resection versus a transplant decision. Coming to patients with cirrhosis, there is a significantly higher rates of post-op liver dysfunction due to impaired liver regenerative capacity and compromised baseline liver function. Major resections in cirrhotics can lead to liver failure, extrahepatic multi-organ failure, or death. Resection and portal hypertension. So this paper was published in 96 by Brew and colleagues, in which they have said that the liver resection for HCC plus portal hypertension can lead to post-op decompensation in 73% of patients. Multiple meta-analyses have confirmed the same, that there is an increased mortality and clinical decompensation in these patients. On basis of this, American European guidelines have guided that presence of portal hypertension may be a contraindication for liver resection. In approach to patients with NASH, it is best to avoid if resection if FLR is less than 30%. However, safety data for resection in NASH patients is limited. So risk stratification for such a patient would be based on the presence or absence of the following 3 factors, which are insulin resistance, cardiovascular disease, and severe obesity. Resection may be reasonable with FLR of more than 30% and no major comorbidities. Additional contraindications would be poor anesthesia candidates, involvement of major vasculature or biliary strictures, extrahepatic disease, this is context dependent, IVC invasion is generally contraindicated, and hepatic vein invasion, it generally indicates a poor biology but is not an absolute contraindication. Coming to BCLC criteria for HCC and portal hypertension, which we are all familiar with, it stages HCC in portal hypertension into 5 stages. This is based on the number and size of the nodules as well as child score and performance score. However, more recent guidelines from Hong Kong liver cancer criteria or HKLC are a bit more aggressive in their approach towards HCC and liver resections. For example, they have clubbed that performance score of 0 to 1 together, and child B. Both of these performance score of 1 or child B, which would previously would not have been candidates for resection, could be candidates in Hong Kong liver cancer criteria. So the main criticism for BCLC is that it is derived from a relatively small cohort of patients, which are a predominantly Western population, thus limited applicability in other areas of the world. It has been criticized to be overly conservative in that performance scores gets a veto over other things. However, multiple meta-analyses have confirmed that it is better at predicting the overall survival. In case of a Hong Kong liver cancer criteria, there is a larger cohort of patients. However, they were predominantly of viral etiology. It is more aggressive in its treatment recommendation. Performance score of 0 to 1 are clubbed together. For example, a child B with early tumor can undergo resection according to this. However, it is heavily criticized because only half of the patients receive the intended curative treatment because physicians or patients also may be unwilling to take up a higher risk elective surgery. This paper was published in Journal of Gastrointestinal Oncology, in which they studied liver resection for HCC beyond the BCLC criteria. So they studied 3 factors or risks, 3 contraindications as per BCLC, but in liver resection, which are multinodular disease, portal hypertension, and portal systemic invasion. So in this, suppose if there is one BCLC contraindications out of these 3, the overall survival was 43 months, disease-free of 15. So they have concluded that such patients may undergo resection. Out of this, if there are two contraindications, overall survival of 6 months and disease-free of 5 months, it looks like a negative impact. However, 2 patients had a significantly much longer survival. So they have concluded that patients with 2 risk factors can undergo resection only in favorable scenarios. If there are all 3 contraindications, which was a single patient in the study, even though overall survival was 17 months, overall the outcome was poor, and they have concluded that there is no benefit from resection if all 3 contraindications are present. Multiple meta-analysis, including this one from Tata Memorial, have studied the resection of HCC beyond the BCLC criteria, and there is justification for hepatic resection whenever feasible, even if tumor is more than 10 centimeters or it's a BCLC B or C or multinodular tumors. Intrahepatic cholangiocarcinoma, first is staging laparoscopy, which is mandatory. Contraindications for resection will be involvement of secondary biliary radicals bilaterally, distant disease, or unreconstructible main portal vein encasement or occlusion. A word also regarding the overall worse survival, which is seen in multifocality, extrahepatic tumor extension, high-grade tumors, lymph node positivity, and age greater than 60 years. Genomic alterations in TP53, KRAS, and CDKN2 have also been found to have worse survival. In conclusion, the basic risk of elective liver resection is now comparable with other elective abdominal procedures, which forms the rationale for extending indications of liver resection. Careful preoperative assessment and surgical strategizing is mandatory. Also, current risk assessment of liver resections is in hospital mortality. However, we should consider newer endpoints since extended criteria of liver are regularly used in liver resections, such as financial and quality of life related endpoints. So, thank you.
Yeah, the other point which you could add is that what is the relative outcome of non-surgical treatment in a given case? That also the soft points which you mentioned I think, Dr. Naimish, we would not ask any question from Mrunal. She has done enough to make a presentation. I would request you to make a comment about this calculation of FLR, especially when the entire, say, right lobe is occupied by the tumor. So what we are resecting is the tumor and very little normal liver is being resected. How should that be taken into account? And second, especially if it is a slow-growing tumor, or if the tumor has already involved the portal vein, what effect does it have? Does it produce any spontaneous atrophy, hypertrophy, and how to take how to evaluate that and how to account for that?
So,
Yes, sir. Oh, sorry. Oh, sorry. Yes, sir.
sorry, fantastic job, Mrunal. Go ahead if you want to take an
Oh,
answer.
no, it's okay.
Please go ahead. Please go ahead.
Yeah, this is not an exam, so you can
Oh,
afford to be wrong also.
yeah, yes, sir.
We are here to correct you, Mrunal. So, please try. No problem.
Oh, okay. All right, sir. If there is an isolated portal vein invasion that might lead to subsequent hypertrophy of the involved segment, so it may work in our favor in that the contralateral side may have overgrown. And also regarding the modern CT with the 3D reconstruction, we can calculate the remnant FLR adequately. This can be supplemented with functional assessment of the liver on the quality of liver that is left behind. So we can have a good assessment of whether that remnant liver will be able to tolerate the metabolic demands of the body as well.
Dr. Naimish.
So, no, very rightly answered. So, for FLR, when you calculate specifically for the larger tumor, what most of the centers do is they calculate the total liver volume. They subtract the tumor volume from the total liver volume, and the part which you're going to leave behind is what they then would divide. So effectively, they are actually subtracting the tumor volume from the total liver volume. But there is a new concept which is now coming in, that what we assume that the whole tumor is non-functional is probably incorrect, because there are still a lot of hepatocytes in the tumor cells. Suppose you have a 15 centimeter large tumor occupying the whole right lobe, or involving segment 4 as well. And in these cases, you will have multiple hepatocytes which probably are not invaded or replaced by the tumor, would be contributing towards the liver function. Now, how we are going to assess this, it's a very difficult scenario. There are a lot of studies now going into address how we can try and assess how much functional tumor is contributing towards the overall liver function. But ICG is one of the modality which is currently available, and the ICG retention rate can give you a rough idea regarding the functional assessment which Mrunal has rightly pointed out. But the answer to the question is, usual way is, once you calculate the total liver volume, subtract the tumor liver volume from it, and then calculate your liver remnant. The second question which sir had, go ahead.
The portal vein involvement.
Yeah, no, I thought Mukesh wanted to speak something. So when you have a portal vein tumor involvement, so again, Mrunal has aptly answered that if it is involving a segment, or even sometimes the whole right portal vein, or the main right portal vein which is involved, it may lead to atrophy. Most of the times, unfortunately, it does not happen that way if it is involving the major right portal vein, where there are some shunts between arterioportal shunt, and you may not see an adequate atrophy of that part of the liver, and you may have to go ahead and if you think that the future liver remnant is smaller, then you may want to augment it. Either you ask for a TACE. Nowadays TACE is still possible with a portal vein tumor thrombus, or you can ask for a liver venous deprivation, where you also try and embolize the hepatic outflow, the hepatic vein. So that way there is probably a higher rate of hypertrophy of the future liver remnant, and then maybe you can go in after a certain period of time. ALPS also, obviously, there is, just to complete the nomenclature, ALPS is still there. We can add that as one of the possibilities, but it depends on case selection, because every ALPS um, does not come out with a successful outcome. So portal vein embolization still has probably got a superior role and advantage as compared to any other modality of enhancing the future liver remnant volume.
So may I make a point?
Yeah, Mukesh, please go ahead.
Yeah, for resection, usually we say 30% in normal liver, and in cirrhotic or NAS, it's like more than 40%. But that is not the only thing. Suppose we are doing a right hepatectomy and remnant is good, like 40%, even 50%. But if you are not able to preserve the middle hepatic vein, so that will give us trouble. Like despite being a good remnant, but if you are not able to save the middle hepatic vein, so that remnant doesn't favor that resection, because that is also very important, because patient end up is having post hepatectomy failure, and that
So
portal vein embolization
sorry to interrupt. So from the student's point of view, what you are saying, that volume is important, but outflow
yes,
also is important.
yes, yes, yeah,
Yeah, please go ahead.
I want
yes.
I want to make a point, sir.
Please go ahead.
Mohammed?
Regarding liver resections in case of HCC, because it is underestimated, because it is a good treatment in absence of the facilities or the patient is not fit for there are financial issues. Still, liver resection is a good alternative treatment because it is nowadays liver surgery is very safe even in elderly people. What is the BCLC criteria is too restrictive, and it has given a wrong, I can say, sort of a wrong impression. The physicians, especially the gastroenterologists, most of them they send patients to for IR for TACE, and those patients are still resectable. And there can be resection can be a good alternative in case of HCC.
So, Dr.
Can I-
Naimish, for the students, I would request you to make a little more comment about this dual venous embolization, portal vein and hepatic vein also.
Sure. So when you are enhancing the future liver remnant, when you want an increase in the future liver remnant, initially when you have calculated, just as we discussed, if the FLR or the future liver remnant is less than what we have been discussing, I'll add some points to what Dr. Mukesh and Dr. Younis has pointed out. So overall, we consider about 30% is what is an acceptable future liver remnant in a normal liver. And if the volume is less, then you need to enhance. For that, there are multiple modalities available. One of them is portal vein embolization, where you embolize the ipsilateral portal vein. So suppose for a CAGB or for a hilar cholangiocarcinoma, your resection entails a right trisegmentectomy, which would mean that you are removing segment 1, 4, 5, 6, 7, and 8, leaving behind only segment 2 and segment 3, which would initially not be enough. If it is less than 30%, then in these cases, you have to embolize the right portal vein. You also have to embolize, in many cases, segment 4 portal vein branch, thereby allowing the segment 2 and segment 3 to enlarge and hypertrophy. So what you are doing in portal vein embolization is you are stopping or obstructing the portal venous flow, but you are allowing the arterial, which carries the oxygenated blood. So you allow the arterial supply to that part of the liver. So the liver usually does not get necrosed. Now, when we discussed is LVD or liver venous deprivation, by that what we mean is, in addition to portal vein embolization, you also add hepatic vein drainage. So in these cases, if you have to do a right trisegmentectomy in association with portal vein embolization of the right portal vein and segment 4 portal vein, you also embolize the right hepatic vein. So thereby, why this concept has come in is because the venous, once you have stopped the inflow, the liver is a fantastic organ made by God, and there are many venous collateral channels through which even those part of the liver which has undergone portal vein embolization may develop newer collateral inflows, and then they can take that flow out as an outflow from the main hepatic vein. So if you add the hepatic venous embolization as well, you are depriving the liver of inflow as well as the outflow and maintain only the oxygenated blood supply thereby allowing the your time period of 3 to 4 weeks for the left lateral, that is segment 2 and 3, to actually hypertrophy. So that is what is liver venous deprivation means, right? Now, when we were talking about what Dr. Mukesh was speaking is about the future liver remnant, not only the volume, but you should also be aware of the quality of the liver. So by that, what Dr. Mukesh was trying to point out is the liver which you are leaving behind should be normal, should not be affected with either hepatic steatosis or chemotherapy associated steatohepatitis. So none of these things. So you need to clear out all these doubts before you actually rely only on the amount of liver which you are, or the volume of liver which you are leaving behind. Another point which was made by Dr. Younis is offering liver resection. There is definitely a point of offering liver resection, but one thing we need to keep in our mind, with the standard operating protocols, the policies now which are in place, if there is a tumor in a cirrhotic liver, liver transplantation has definitely given better outcomes. But some centers which do not have the option of offering liver transplant, or the patient does not by any mean want to go ahead, or for whatever reason do not wish to go ahead for liver transplantation, in these cases liver resection may still be attempted in selected cases and in experienced hand.
Also, Dr. Naimish, I would request you to give a few tips to the students about liver resection when doing it in a normal liver, and when, as you said, that in some situations it may have to be done, say, in a cirrhotic or a steatotic liver.
So when you are
Both in
doing,
terms of selection as well as the technique, since we have some time.
sure. So we'll try to keep it brief, because all these three parts of the question what Dr. Kapoor sir was asking, they are in each of the single one. You can actually talk about 20-25 minutes on each of these topics. So I will try to keep it as brief as possible. One is selection of the patient is very, very important. Apart from the usual selection, you also need to identify whether you are going to do an anatomical liver resection or you are going to do a non-anatomical liver resection. Most of the time when you are actually, for the newer and the younger surgeons who are embarking on liver surgery, I would suggest that if you don't have that much experience, or you don't have experienced surgeon available at hand, then in the initial few resections, try to keep yourself accustomed to anatomical liver resection, where the chances of bleeding would be comparatively lesser. Remember that liver is like a sponge. It is a highly vascular, solid organ in your body. So any change in the plane, and if you do not follow and do not respect the liver tissue, it will not respect you back and will lead you into a bloody cycle, which Mrunal was trying to point out, that if you have bleeding or hemorrhage, it can lead to hypotension, hypothermia, low pH, which in itself will become a cycle where you are not able to get the patient out, and you may end up losing this patient. Coming to liver resection in cirrhotics, here you need to be careful. One is the liver is much more firm, whereas in a normal liver, the liver is much softer. So what you need to do is, when you are using CUSA, which is the most commonest form for liver parenchymal transaction technique, you will want to increase the CUSA setting depending on how hard or how much cirrhotic the liver is, because the same settings may not be applicable in a cirrhotic liver. You may not be able to find your way forward when you are doing liver resection in cirrhotics. Another point important to be made in liver resection, either cirrhotic or non-cirrhotic, specifically for the beginners, is loop the whole porta or the hepatoduodenal ligament and keep that ready for Pringle's maneuver if you encounter into a major bleeding vessel. If you are able to loop inferior vena cava below, and if you are able to loop the inferior vena cava, which is in the suprahepatic region, In case you end up in a major bleed, you may be able to perform a total vascular exclusion if possible. But minimum what is required is looping of the hepatoduodenal ligament to keep yourself prepared for a Pringles maneuver.
Yeah. Any other panelists would like to make any comment? We still have a few minutes.
Sir, may I
Regarding
make
the
a
liver resection for a beginner or a beginner setting, we had to inform the anesthesia team to keep the central venous pressure low and to talk to the anesthetist and communicate with the anesthetist regarding the central venous pressure and all that. And that will help in a great way in reducing the bleeding. And in case, as Sir has also told her to keep the Pringle at hand so that the major blood loss can be prevented. But the one golden rule is it is a mathematics like liver. It has a good results if we follow the, if we prepare the patient well, if we plan the patient well, it has a very good results. But it can have disastrous consequences if we don't do our planning well. Right from the admitting the patient, do the thorough investigation, discussion with the radiologist, discuss the anatomy in detail, and to know the aberrant anatomy, and preparing the patient well, and then following the protocol and be slow, follow the standard protocols. So this is the rule. So we have to be very meticulous, and it is a rewarding.
Yes, Mukesh, you were saying something?
Sir, nowadays tear has come in a big way, especially in cirrhotic background when liver resection is risky and gives even in smaller lesions equally good results like resection. Yeah.
Yeah, so since you have raised that point,
Yes.
I would also like all of you to make a comment on uh, which arterial intervention can be done if the portal vein is already invaded by the tumor. That's something which students are often asked.
Sir, if portal vein is inhibited, usually earlier it TACE plus SBRT used to be done, but now the tear has come, so tear also take care of the portal venous invasion. So nowadays our practice is HCC with portal vein invasion. Go for tear first. Yeah, Naimish sir can
Just
comment. Yes,
yeah,
sir.
so just to add, so I think tear, yes, definitely it has come up in a big way. But most of the major centers who are performing transplant, the reason why tear and SBRT is the short beam radiotherapy being used is mainly to downstage this tumor.
Yes, sir.
So
Yeah,
you are trying to dissolve the portal vein tumor.
yes,
Again, that is divided. The portal vein tumor thrombosis can be classified into VP1, 2, 3, and 4, depending on the segmental
branches.
or the lobar or the main branches which are being involved. So here what the intention, what Dr. Mukesh was trying to point out is TARE will try to downstage the tumor, see the biology of the tumor. It helps you to reassess this patient in about 6 weeks time, assess the tumor markers with alpha fetoprotein and PIVCA, and if you see a good response, and if the portal vein tumor thrombus is VP1 or VP2, which is the segmental branches, then in these cases, if you offer liver transplantation, you may have some benefit in these specifically selected patients. So yes, overall tear now is definitely coming up in a big way, but the main reason probably to it is we are trying to downstage and offer liver transplantation to these patients, which when we started doing transplant, portal vein tumor thrombosis, even segmental, was
No,
considered as a strict
no,
contraindication.
no.
Nobody even would even look at them again. So now we are able to offer them some hope, and that is why tear has now come back in a big way.
Yes.
So
Both are
since we
actually
have, yeah,
bridging,
Saurabh.
both are actually more like a bridge therapies as well as something to assess the biology of, as sir said, biology of the tumor. So if actually I went to a meeting today only where transplant was advised to a HCC patient where TACE was done and all the markers actually came down, but the thrombus was there still in the portal vein, and so he has been, so he needs funds. So obviously the question from the gastroenterologist was about technical feasibility. So I said technical feasibility is only at the time of the operation table. Rest of the stuff can only be judged on the basis of tumor biology. So if the tumor has responded so well to rest of the treatment, so probably it's a one sign or hope which you could provide to such patients. That's what it is. But my take was on the volumes part, because I feel that even if we assess 30%, 40%, even 50%, per se, just the volume may or may not indicate the right final result of the surgery, because whatever volumes we usually profess as when rest of the course of the surgery actually goes very smoothly. So any bile leak actually could lead to something, or any complication leads to more chances of decompensation in these patients. And even if you have a pre-operative volumes to a tune of 40% or even 45%, the patient may not behave as well as we actually predicted pre-operatively. That is a very big issue. And although we say that ICG is a good modality, but I'm not sure many centers are actually still following ICG to the hill tag. So that is something which is a kind of a gray area. And second thing is, sir, is there a age bar to where you would suggest resection for a surgeon for a HCC?
Dr. Naimish, आपका muted है.
Yeah, sorry. So,
Age.
no, very, very rightly pointed out. I think we have discussed some of these points, and yes, availability of all these newer things in every center definitely has its limitation. There are financial limitations also involved. In terms of the question asked by Dr. Saurabh, is the age. Well, so there is no real age criteria. It all depends on the functional status
Yes.
of the patient and what is his ECOG status, if there is any comorbidity, if the patient is suffering from. So I remember doing a liver resection on an 80-year-old as well, and we have done a liver transplantation on a 78-year-old as well. So still 70 is at some places, 70 being the cutoff. Yes, we need to have a cutoff, but I don't think it is applicable to each and every patient, and it is not gospel truth. If they are your patient who is physically fit, is able to withstand a major liver resection in your opinion, then I think you should still give them a chance rather than writing them off, because it all depends on, once you operate on these patients, what fruitful life are they going to give, you are going to give them, how much they are going to go back to the society, is it going to be helpful to the individual and to the society and the family at large or not. So all these factors need to be kept in mind before you actually either offer or you discount and doing transplant on them. Transplant or any liver resection for that matter.
Yeah, per se, actually, we are offering resections even in cirrhotic patients, even if there are large lesions. Like very recently, we did on a 7 centimeter per lesion, which was subcapsular in segment 6. So only thing is that we weren't going for an anatomical resection, we went for a non-anatomical resection, and patient had a decent outcome. So that ways, even resection can be, if you go by BCLC, probably it will not fit in the resection criteria, but then you have to pick and choose
No,
with regards to the patient.
sorry to interrupt, but let the message go to the students.
Oh,
The
exactly.
standard,
So that is my
yeah.
question basically.
Yes.
That what should be the limit where we stop ourselves in regards to resection? So
I
that
think
is,
rather than the chronological age, it should be the physiological age, which also takes into account the nutritional status, the performance status, and the comorbidities as far as the patient is concerned. And then very important, as Dr. Naimish mentioned, the surgical team's experience. So what you have done probably would not apply to everyone. And the logistics, what all is available in the institution. So we have a tradition to start in time and finish in time. So before we close, I would like to once again thank my colleague, Dr. Naimish. Um, I I don't have to thank him in the department, but here I should. Thank you, Dr. Naimish, for sparing your time. And uh, without you, this session could not have been so useful. Thank you very much for your
Thank you, sir.
comments, and see you tomorrow again. And I would like to thank all the speakers, Mohammad, Mukesh, Saurabh, and a special thanks to Mrunal. I'm very happy, and I would say again, I'm very proud of you that you volunteered. And if Dr. Naimish said it was a good presentation, it was indeed a good presentation. So thank you so much, and I welcome you. And thanks, Krishna Rao. Krishna Rao is one of the panelists tomorrow. He's also one of my former students from SGPGI. He will be a panelist tomorrow. Thanks, Krishna, for joining. And I would like to thank Anand Nagar, my colleague, who's been looking after JST for last 4 years, very meticulously arranging all the sessions. And thanks to Avinash Tank, Dwarika Hospital in Ahmedabad, and his team.
Thank you, sir.
Of IT professionals who have been managing all the online activities, JST, masterclasses, and the Jaipur Surgical Festivals. They have religiously recorded all the sessions and posted them on the YouTube channel for all the students. And as I said, that some of these masterclasses have gone to the more than 1,000 views. So I'm very happy that all your efforts are being useful to the students. And once in a while, students do send me a feedback that these sessions are useful to them as far as their exam is concerned. And I'm sure they will be useful to them when they start practicing GI and HPB surgery also. So with that, Dr. Naimish, with your permission, can we close this session and say good night to everyone?
Yes, sir.
Thank you.
Thank you so much.
Thank you so much, sir. Thank you.
Thank you.